This is again sponsored by Sanofi Genzyme. It's like a discussion between three specialists, and the theme of the session is type 2 inflammation with discussion of real life cases. So what I'm going to do, I'm going to set out the scene for our expert panelists, and then I'll let them present their cases sequentially. Okay, so this is the simplest definition of inflammation. So inflammation is basically a body's immune system response to an irritant. So an irritant being in the skin, on the airways, anywhere on the gut. So and all of these would lead to inflammation. We have three types of inflammation. The one that we're concerned about today is type 2 inflammatory pathway, and I'm not going to bore you with a lot of, because I think you've heard enough about type 2 inflammatory pathways and the cytokines involved. But to just mention that this pathway is really involved in the main atopic disorders, including atopic dermatitis, asthma, rhinosinusitis, nasal polyposis, food allergy, and eosinophilic gut disease. Now, type 2 inflammation actually was developed to fight parasitic infections. This pathway uses the different mechanisms to actually get rid of the helminthic infections. So they induce increased mucus production, contraction of small cells to expel the parasite. However, because the helminthic infections are rare at the moment and mostly absent, the immune system becomes dysregulated, and it turns to environmental allergens and can cause inflammation and atopic reactions that result in conditions like atopic dermatitis and asthma. As presented by Fulvio earlier, the target organs for type 2 inflammation include the gut, giving rise to eosinophilic gut disease, atopic dermatitis, skin is involved here, chronic rhinosinusitis, where the upper airways are involved, and asthma and eosinophilic COPD, where the lungs and lower airways are involved. So there are multiple factors contributing to the pathogenesis of type 2 inflammation, and so it's not a single factor that leads to this inflammatory pathway. So it has to be a combination of multiple factors, including the immune response and the inflammatory process, barrier dysfunction, and there has to be a genetic predisposition. So you can't develop this type of inflammation or direction of where the immune system reacts without genetic predisposition. Also, the environmental and microbial factors are also important in initiating this type of inflammatory process. Now, most of you would know that patients with one type 2 inflammatory disease have an increased risk of developing other diseases driven by type 2 inflammation. For example, if you look at patients with atopic dermatitis, asthma occurs in patients with severe atopic dermatitis in a quite a substantial number. So about 1/3 of patients with atopic dermatitis would have severe asthma. Also, nasal allergies, hay fever occurs in patients with severe atopic dermatitis in up to 60% of them, and so on and so forth. If you look at the asthmatics, for example, 26 to 50% of patients with asthma have upper respiratory disease, nasal polyps, etc. And again, these patients would have asthma and have allergic rhinitis. So it's important to understand that if a patient has one type 2 inflammatory disorder, they most likely have a second or a third inflammatory disorder. And I think I'll now leave the floor to Dr. Fatima Al-Breki, who's one of our expert panelists. Dr. Fatima is a consultant dermatologist and chief of dermatology division in Tawam Hospital. She's a scientific committee chairperson of the Emirates Dermatology Service. She previously was the chief of dermatology services in Al Ain Hospital and AHS Eastern Region. She has a fellowship in pediatric dermatology from South Africa. Her great interest in inflammatory conditions, especially psoriasis and atopic dermatitis. She's actively involved in many local and regional conferences and events as a speaker. She's also actively involved in international research and in teaching. Dr. Fatima Al-Breki, a pleasure having you with us. Please, the floor is yours.
Okay. Assalamu alaikum and good evening, everybody. I'm very proud to be between you this evening in this event. And let us start with atopic dermatitis. We all know that atopic dermatitis is one of the common conditions that we almost see it every day in our clinic. 20 to 30% of patients have moderate to severe atopic dermatitis. And this is not a small number to ignore. And there is a large unmet need in having that safe, effective treatment that has a long-term efficacy. So let us start with the first, with my case. This is my only case that I will present today. 12-year-old boy who presented to my clinic with severe atopic dermatitis and bronchial asthma since childhood. His EASI score, this is one of the scores that we use it in our clinic. So his EASI score is 30, and this means that he has severe disease. And his DLQI, Dermatology Life Quality Index, was 25. That means this is a questionnaire that we give it to the patient to fulfill it. It's like 10 questions. And we calculate the quality of life after they answer these questions. So he was highly affected by his condition to the extent that he doesn't go out. He doesn't even come to Dubai, as he said to me. And he was always isolated, and he was suffering from bullying in the school. He failed on topical treatment. I put him on phototherapy for some time, few months, and I didn't see any change. He had mild improvement with cyclosporin, but unfortunately he developed hypertrichosis, and the mother decided to stop the treatment. So I moved to methotrexate at that time, and he was on methotrexate for 4 months with no improvement. And finally, after we got the approval in adolescents in 2019 in UAE, I started this patient on dupilumab. And there was a dramatic improvement in the adolescent condition, to the extent that he told me that I'm now able to go to Dubai, finally. So mother also noticed an improvement in his asthma. This is my patient before the treatment. I hope, sometimes I feel that the photos do not express really what the patient feel and what we really feel toward our patients. So you can see all these follicular papules on the lower extremities with lichenifications all on all his dorsal aspects of feet. You can see a close photo to the lichenification with all these excoriation and maybe a hint of impetigo. These all follicular papules that never disappeared with any of those treatment. Even with the topical treatment, he got worse and worse. Again, you see the lichenification on the upper extremities. Again, you see the lichenification and the hypopigmentation due to a long-term use of topical steroid. Neck was affected. And this is after few months of being on dupilumab, where you can see all these follicular papules started to disappear. The lower extremities become much better. The skin texture become much better. Again, you can see few lichenification, but again, it's much, much better. The patient quality of life changed dramatically, and he's able to sleep, go to school, perform well. You see the neck and the other photos of the extremities. And this is a recent photo of my patient where you can see that almost clear lesions of his legs. My patient now on dupilumab for 3 years, continuously, every 2 weeks, with no problem, with no side effects noticed, happy with the regimen. He just uses topical emollients without the need to use topical steroid. So I just want to show you how difficult is our clinic when we need to do some scores to convince the insurance company that our patient really need those treatment. And you know that we have a lot of scores, but I usually do the easy score eczema area severity index score that assess the severity of the disease. And you have to have at least 20 to 30 minutes to do this score. You have to examine the patient fully and do this score. And you have to do it every time you need to refill the medication to convince the insurance company that this patient is doing well. We have other scores that we can use it from time to time, like SCORAD score, which can assess not only the severity of the disease, but also the extent of the disease and the symptoms associated with the disease, like itching. We have the IGA, which is the Investigator Global Assessment or the Physician Global Assessment, that the doctor assesses the severity of the disease, giving numbers 0, 1, 2, 3 to 4. We have the numeric rating scale, which is an itch score, BOEM score, this is patient-oriented eczema measurement, and the LQI, which is the Dermatology Life Quality Index. Sometimes the insurance company asks for 2 or 3 of those scores, and our life got miserable. So simply the score, we have to assess each part. We have 4 parts that we need to assess each of those parts in regards to the erythema, infiltration, excoriation, lichenification. And we have to calculate numbers and assess the patient and put the score whether the patient has mild disease, moderate, or severe disease. So dupilumab changed the life of our patient dramatically. I'm very happy I have a bulk of patients in my clinic that from 6 years old and above. And the first patient actually who got dupilumab in the whole United Arab Emirates was from Tawam Hospital. She was my patient actually, and I hardly see failure with the dupilumab. I don't have right now any patient who failed on dupilumab. They are doing great. They are happy. You can see a dramatic improvement at the first 2 weeks, and you can see the good results that last for a long time of those patients. So this is one of the studies that shows that there is a dramatic improvement from as early as day 2 in children and day 5 in adults, day 2 in adult and day 5 in adolescents. And by 15 days, which is 2 weeks, you can see that at least there's a 25 reduction in the big pruritus NRS, numeric rating scale, in those patients who received dupilumab versus placebo. And Dr. Muna earlier mentioned about the side effect that we see it with dupilumab. The most common side effect we see it with dupilumab is conjunctivitis. I have only 1 case with conjunctivitis who is doing well now after we educated our ophthalmologists about the use of the right treatment for those patients and to encourage those patients to stay on their treatment. Conjunctivitis will go one day, it will not be there forever. This patient actually used some topical treatment. She didn't reach to the cyclosporine topical. She was using other topical treatment from our ophthalmologist, and she's doing well. The mother was insisting to stop the treatment, but I was encouraging them to keep her on the treatment because she's doing very well, and the conjunctivitis will subside one day. And that's it.
Maybe you give it.
What time you want to stop? Do you have any plan for this one?
Yeah.
For the patient?
For the children, there is a chance to outgrow it. 80% of the children, they might outgrow the atopic dermatitis, but for the adolescents and the adulthood, atopic dermatitis, most probable that it will persist. So if I'm going to give a treatment for an adolescence or an adulthood, I just tell them that this is a chronic condition that will persist. There is very, very low chance that they will get rid of it. So I don't do any spacing. I just continue on the treatment because this is the recommended dose and this is the dose that they improved in. I tried to do that one day with one of my patients and I saw some relapse. So I prefer to keep. He was supposed to take every 2 weeks and we did it every 4 weeks for 2 months and the patient started to relapse, unfortunately. So we went back to the every 2 weeks. The second question. Yeah. Children, yes. Children, I might stop, yes, because they might outgrow it. So we'll see how they will go with the treatment later on. But the adolescents and the adults, no, I have to continue with the treatment.
Can I just ask you one question? We've patients that we've spaced the treatment. So, for example, they did well on 2 weekly regimen. So we've asked them to extend to 4 weekly. Has that been contemplated in this patient? Because apparently,
I don't do it with.
Yeah, because I remember
especially when they are over 50 kilograms or over. They should receive the.
Right, but have you tried? So because this guy is doing very well, so I think it's worth probably extending because we've done.
Sometimes they skip their injections for like 1 week, and you start seeing some relapse of those patients, and you prefer that you should keep them because you don't want to see. They also come quickly to you in the clinic, just catch on and not to start to be relapsed.
Right, and I think the compliance is a major issue. Do you have a problem with compliance with these patients?
With dupilumab, I'm very happy that my patient comes regularly to the clinic, and we have a nurse that can serve them in the
at home, yes,
house,
yeah.
At home, yeah. So they are very happy, and she follows regularly with me for refills.
Excellent. And conjunctivitis, I concur with what you said. We haven't seen it actually. At least I haven't seen it in my practice.
One case.
Yeah, I mean. Yeah, they don't report it. I'm not sure. Probably we're not doing a good job in sort of interrogating patients about it, but it's not a common thing that we see really.
Yeah, I have one case only of conjunctivitis, and I'm very happy with her progress with the treatment with her ophthalmologist, and she's doing very well now. Her conjunctivitis is under control, and she is doing well with the eczema. So I'm not planning to stop dupilumab. Yeah.
Thank you very much
Thank
indeed.
you.
Thank you. Thanks very much indeed. Fantastic. Excellent. Our second expert is Dr. Ashraf Zahabi, who is going to present his case.
Yes.
And Dr. Ashraf, as you know, is the president of the Emirates Thoracic Society. He is a consultant pulmonologist in Zayed Military Hospital, and he's very famous.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Boumar'i. This is the last session, Boumar'i, yeah? Okay, that gives me a relief. A long day for all of us. I've been asked to present to you a case. I present this case. It's a common case of an asthmatic patient, but there are some questions that I'd like to share with you. I don't have answers for these questions. These are my disclosures. Muhammad is a 37-year-old man. He's non-smoker. He's obese. BMI is 33. Known case of asthma since childhood. He has no other comorbidities. He was referred to us from a secondary healthcare clinic for his poorly controlled asthma. Dust in working in the military has increased lately, and he became symptomatic with dyspnea and nasal blockage. On regular examination, on regular medication, he is already on ICS LABA, tiotropium, and with good inhalational technique, takes anti-leukotriene, and he takes inhaled nasal corticosteroids. He has history of prior history of admission, acute exacerbation due to asthma that required systemic steroids. His ACT score shows uncontrolled asthma, 12, less than 20. He has wheezed bilaterally. We did an ENT consultation, and our ENT colleagues told us, Ashraf, he has pan-sinusitis, and they recommended for him surgery, the functional endoscopic sinus surgery. And this is the consultation and the CT scan finding from the ENT doctor. I do a spirometry for him, and his lung function shows very low FEV1 of 1.15, only a 31% the predicted for him. And the FEV1 after bronchodilator went up to 1.6, so 300 ml reversibility, which is 40% from his baseline. IgE is 641, eosinophil count is 25. He had his RAST allergy panel, aspergillus, vasculitic workup, all negative, and his FeNO is 116. Which biological treatment would you use for him? First of all, he's severe asthma and he's uncontrolled. Since this is a small group, we're here together. Any suggestion? Dupilumab. Is there a room for another biology? Xolair, omalizumab. His eosinophil count is 650. 640.
For omalizumab.
Okay. He does not have, the RAST is not. So he, we did the CT chest. We were, again, work up for making sure we're not missing anything. He doesn't have bronchiectasis, no structural lung disease. He does have mosaic pattern, and we related that to airflow, small airway disease because of his uncontrolled asthma. He was actually, what I didn't tell you, he already was started on omalizumab before he came to us, and that's the usual. Sometimes omalizumab is easier access for a lot of secondary care clinics. So he got omalizumab. However, only after 2 doses, he did not feel that his asthma is any better. Actually, his asthma got worse. And you know, we usually tend to ask the patient to take the medicine for how long? 16 weeks before we claim omalizumab is not working, because a lot of those patients with time they improve. He would not listen to us. And next month, he had actually an acute exacerbation, was admitted to the ICU because of his asthma. We introduced dupilumab for him, and this is retrospective, he had a remarkable improvement. The thing with dupilumab, I have to say, since I started use it, those patients, when they respond, it does work significant. They tell you stories. They tell you stories. Before they go home, they'll tell you their success story and how better they feel. So he was a dupilumab responder. No new episode of acute exacerbation. ACT questionnaire is 22 now, and his PFT improved 31%, gradually improved to 63. So his lung function has doubled. And his FeNO went down from 116 to 35. Patients continues his other controller. So I just wanted to share this story with you with a caveat of his eosinophil. I told you about his eosinophil being 600 when we started. It went down after dupilumab, and then it peaked again. Do you see this in your practice? Yeah. They report eosinophilia, but 10% patient. Does it persist? They're saying, I saw in one of the studies, and I'm sharing here one of the studies, that 52 patients at the start, 4% who received dupilumab as compared to 0.6% who received placebo. So there is this 4% of patients who might develop eosinophilia. And this was a New England Journal of Medicine. But I noticed that in that same article, they said 7 out of 15 patients actually had to stop dupilumab because of the xenophilia. I don't know why. Is that because of the number or there was something else? And I put this case for you because of two things. Because this was a case of successful response to dupilumab. At the same time, this persistent xenophilia, and it's very high. By high, I mean, you see how high it is there? 2,500. And if it persists for 2 years, does it bother you? Do we consider doing something else? His FeNO over the years, over the couple of years, 116, 61, 35. Clinically getting better. Type 2 inflammation is getting down. His lung function is getting better. No exacerbation. You remember the 1.3 FEV1? It's 2.39 now. So he's doubled his FEV1. So he had a good response. And I thought I'll share with you, if you have experience, you're the immunologist, you should tell me, should I worry about 2,500 absolute eosinophilic count? No, I'm talking about, it's like, it's not 0.300. It's not 0.3, which is 300. It is 2.4 absolute value. You know what I mean?
Yeah, I'll keep an eye on him because I'll tell you, we had a patient who actually developed a systemic reaction to Dupi, where one of her main manifestations was xenophilia, but she had also urticaria as well as arthralgia, etc., etc. Now and raised the CRP actually. So we've stopped Dupi and everything went back to normal. However, her eosinophil count persisted, it didn't go back to normal entirely, but it's, slightly above the normal range.
Yeah.
And we kept an eye on her. She did extremely well on Dupi, and we just kept a watchful.
This guy was 0.6 when we started. So the absolute value, 0.6, which is 600, went down to 0. And then slowly, 0.6, 1,000, please. Can we get the microphone, please? Because I'm here really to learn with these.
So the fact interesting is by basically inhibiting, blocking IL-4, in theory you decrease the trafficking of eosinophils into the tissue, so you might have a transient increase in blood because they don't go into the tissue. The interesting thing is if the patient has a reason for having a trigger, so something that keeps his eosinophils very high, like a clone producing IL-5, that might explain why he has a very high thing. So I will keep an eye on the possibility of having, for example, a hypereosinophilic syndrome, which is always possible and needs to be considered. But of course, the easiest thing would be see if stopping the medicine, everything goes back to normal. But the problem I know would be the fact that he
was in ICU.
Exactly.
He feels great.
But I think, doctor, we have to keep on the clinical because we treat the patient as a human being, not looking too much for the lab, because sometimes labs in immunology mostly confusing.
Yes.
Sometimes
we don't react to numbers. But what I wanted to share here also is that in that article it says 7 out of the 15 patients stopped who had persistent eosinophilia stopped it because of the eosinophilia. And I don't know, did they stop it really because of the number or something else has happened? I thought maybe you might know.
When doctors see eosinophilia high, they want some document that.
Sure.
So when they see eosinophilia high, they respond for us why it means not working.
Yeah. But we know this is not scientific, of course.
Yeah.
Dr. Ravi?
Dr. Ashraf, what about ANA profile and ANCAs done? Are they done in this patient?
Yes, sir. So we did all the, on this slide here,
Okay.
C-ANCA, the P-ANCA, the ANA, all negative.
I mean, if we see this case, the FeNO very high in the beginning is suggesting that sinus inflammation is the key driver, and rightfully probably, we all from the beginning would have started dupilumab. But if the eosinophil went down and coming, is there a secondary eotaxin signal? That's the question.
A secondary what?
Eotaxin 3 signal, So, and where would that come from is the concern. And I'm still, probably I would image the sinuses, even though
you would what?
I would do imaging of the sinuses.
Imaging, there is a CT scan.
Like now,
Oh,
even though
repeat
it's clinically better.
Repeat it.
Yes,
Looking
yes.
for what, Dr. Avi?
Because I want to see if there's any fungal component coming in the sinus. Where would the eotaxin come from? There are not that many sources.
Sure.
Either is it systemic? You're saying that ANCAs are all negative, ANA is negative, or is it a monoclonal proliferation like what Dr.
So maybe reassess even the serology and repeat the imaging. Make sure that we're not missing anything. Something else is evolving.
Yeah, because mild elevation by shunting initially has been noticed. If you see in the original omezumab data, we have seen a lot of IgE fluctuations and raised because of binding and increasing the half-life, whereas the mast cell binding is not there. But with all the biologics which are targeting the IL-4/13 or IL-5, there is no report of sustained elevation. So definitely there is a source in this patient. Is it an occult helminthic infection which is now getting prominent, or is it a monoclonal proliferation, or is it like unmasking of an underlying autoinflammation, or is there a sinus fungal involvement? So these are a couple of possibilities.
Thank you for your thoughts. I mean, 4 months, eosinophil is down to 0, and then that is May. September, and went up there, it went down from 2,400 to 2,000 to 2,000. So, but still high. But thank you. I thought thank you for that. I'll definitely consider that. Thank you, Dr. Muhammad.
What the concern is his raised eosinophil count.
Yes.
He is clinically otherwise well.
Doing well. No ER visits. No ICU admissions. Improved. He actually doubled his lung function, and his is gone down from 116 to 36.
Is he on any medication that might drive the?
He has no other comorbidity except from his obesity, and he is only on the inhalers. But he takes his ICS LABA, antitropium, and the nasal steroid. And we're trying to avoid, since we have Dupi now, hopefully he won't need to have the sinus surgery.
Excellent. Okay, thank you very much.
Thank you very much. Thank you.
Thanks very much indeed. Excellent. I think we move on to our last speaker here, Dr. Tamer Izz. Dr. Tamer Abu Izz or Tamer Izz? Okay, Abu Izz is a head and neck surgeon. He's senior ENT consultant in Al Qasimi Hospital, MOH Sharjah. Since 2019 until the current date, he completed his graduation in the prestigious Ain Shams Medical College. In Egypt, he was selected for Masters and MD in the same institution. Dr. Rabi'ul Izz practiced otolaryngology and head and neck surgery in Shams University Hospitals as a lecturer and associate professor until he was selected as a head and director of ENT unit in Ain Shams Specialized University Hospital during 2018 before moving to Sharjah 2019. Dr. Abu Izz, the floor is yours.
Thank you, Dr. Zarqouk. Thank you so much. Thanks, Sanofi, for giving me this opportunity to present only one case. I hope I can present more cases because now we have like 2 years experience using dupilumab, treating patients with with chronic rhinosinusitis together with nasal polyps. First of all, I'm not sure if any of my colleagues from ENT here, but I would like to just give an introduction about the nasal polyps. You all know that nasal polyps are soft, painless, non-cancerous growths on the lining of the nasal passages or the sinuses. They hang down like teardrops or grapes. Of course, this is the extreme view of nasal polyps. Recurrent nasal polyps causes broadening of the nose, like you see. And now, of course, we have different kinds of clinical as well as radiological grading of nasal polyps. So now we have used the biologic treatment for the last 2 years, and now we have good experience in using biologics treating patients with extensive nasal polyps together with chronic rhinosinusitis. So what about assessment of patients together coming with nasal polyps? Now we have history. We stress on recurrent surgery. Of course, we ask about smell, we ask about the quality of life, but we have another tool, which is the Snot 22 now for subjective assessment of patients with nasal polyps. Now we stress on recurrent surgery, recurrent disease after surgery. when we do examination for the first time in the clinic, we used to have grading of the nasal polyps on each side separately. So we used the Hadley scoring system using the 0-degree scope to grade the patient from 1 to 4. I will not go through the grading, the clinical grading of nasal polyps. And then we ask for the gold standard examination, which is the CT scan sinus without contrast. Sometimes we ask for MRI when we suspect a complication or intracranial extension. Sometimes we need to have another image, which is MRI, but only CT scan without contrast would be enough. And then we do a scoring system, which is Lund-Mackay. It's a very famous scoring system. And then we go to the laboratory investigations like blood eosinophilia. Actually, you don't do other than this in our center. And then if we have previous surgery, we go for histopathology to see the extent of the pathology of the nasal polyps. Sometimes we ask for a smell assessment and then Snot 22. Actually, since introduction of Snot 22, we got benefit actually from this because we can compare the quality of life of patients before and after treatment. So this is the Arabic version of Snot 22, as you can see here. And then I'll show you the improvement on this selected case. So the available treatment tools for patients with nasal polyps are the steroids, which are the mainstay, either systemic, topical, and topical, maybe sprays or drops. Surgery, unless contraindicated, unless we have a systemic contraindication or local contraindication for surgery. And then now we have the biologics as another weapon to use against patients with recurrent nasal polyps, and then the other treatments like nasal washes and saline irrigations and like this. So our patient today, I will present only one case, a male patient, 39 years, with bilateral complete nasal obstruction and total anosmia. This patient is known to be asthmatic on inhalant therapy, previous nasal surgery twice, and then patient is using systemic steroids on and off without any definite history, short-term systemic steroids because he was treated in many centers. So this is by history. And then on topical nasal steroids for several years. The patient knows by heart the names of all the topical steroids in the market. And then we did Snot 22 for this patient, and the score was 46. I'll show you now the improvement. So our patient came and refused any other surgery. He refused totally to do another revision surgery. And then we started dupilumab, 300 milligrams injection twice a month for this patient together. And we kept him on mometazone, nasal spray for 3 months. And then we did CT for reassessment after 3 months. And then we repeated the Snot 22. So the patient had marked improvement and continued treatment, marked improvement in asthma symptoms as well. So these are the CT scan before and after treatment. Actually, when we revised the CT scan, the old one, the starting CT scan, when we changed the window, we noticed that this patient have very high possibility of having allergic fungal rhinosinusitis because of these concretions. This is a soft tissue window and this is bone window. So by revising the CT scan, this patient was having allergic fungal sinusitis, recurrent allergic fungal sinusitis. And this is the view after treatment with dupilumab after 3 months. Patient, of course, started to regain his nasal airway. Another scan showing also the marked improvement. And this is a posterior choana. It was blocked totally before treatment. And then after treatment, it was clear. And here is the Snot 22. As you can see here, nasal, the first half of the Snot assesses symptoms, real symptoms of the patient, like nasal obstruction, smell, and extra. The other half assessing the quality of life. So patient dropped to 8, only 8, the score. The Snot 22 dropped to 8 after 3 months. And then we continue treatment till now patient is on dupilumab. So this is the only case you allowed us to present. And now, any questions?
Can I just ask you, this is, sorry. What's your thoughts about starting Dupi without surgery?
Okay. So We have the IPUS 2020 and we have the Euphoria guidelines as well. So we stick first to IPUS. We offer surgery for patients for the first time because we have to follow the guidelines. But actually, during the last 2 years, we had the COVID, and many times we have blocked the elective surgery. So we have many patients started before even first surgery, and they did very well. And I have many patients, the pre and post, they really improve. So without patient naive, surgery naive, yes, they do very well.
Yeah, you have no sort of strong feelings about starting patients on, because your other colleagues don't have the same view. They said, look, let us stick to the guidelines. And
actually, there are guidelines showing that if we have 4 criteria, we can start without, the presence of asthma, the patient is having high eosinophilia, the patient is having a disturbed smell. So if we have so many, more than 4 criteria, we can start without a history of surgery.
Yeah, it depends which one you follow. Is it
IPUS or Euphoria?
We've recently published the.
Yes, I know this great article. Actually, it goes with IPUS more.
Exactly. Yes.
But like I said before, we last 2 years we had the chance we were pushed to try the Euphoria guidelines actually, because we don't have the chance to do elective surgery and many times. So we started with biologics.
Great stuff. Any questions? We've a couple of questions. Ahmed, of course. Yeah.
Thank you. Yes, we're still surgeons. We need to do surgery, but actually we have some problems in recurrent surgery because sometimes we have complications. We have exposed meninges, so there are many complications, especially with allergic fungal sinusitis patients.
Yes.
So if we have another weapon in hand, it would be very great.
Absolutely. I think the mindset of the ENT surgeons is changing. I think, which is good because
Yes.
you have a medication.
Yes, the benefit of the patient.
The benefit. The problem is how long you're going to keep the medication for. I mean, any ideas? How long do we need to treat these patients for?
Actually, till now, I have no real practice regarding stopping the treatment and then beginning the treatment again. But I have many patients refusing to stop the treatment because they experience the recurrence after surgery.
Yeah.
That's why they are pushing me to continue on treatment. Yes.
Excellent. Dr. Ravi.
So I want to make a comment. What if post-surgically? So if you look at the data, what percentage of patients, especially with the type 2 and fill all
Yes.
the criteria, have recurrence after surgery? I guess it's 40 to 60%, right? Like,
Yes.
what percentage of patients, if they just have the surgery, will have recurrence? Especially if they fit in all the criteria, the type 2,
It varies from center to center, but yes, on average, 50%.
Yeah, 1 in 2, right?
Yes.
So what we thought of doing is, if yes, debulking surgery is the recommended as per the guidelines and the surgeon is doing. So what I've been convincing the surgeon that after the surgery, why to take a chance, especially if it's a type 2 patient, and start the biologic therapy so that the post-surgical outcomes are going to be much better and there's going to be a prevention of recurrence. I think, Dr. Buzak, we need to kind of, the centers, do this where post-surgically we put them on dupilumab because there's no such data. Because 1 in 2 will anyway have a recurrence if it's a type 2. So if the debulking surgery is desired and patient is willing and the surgeon wants to do it, what if post-surgically we do this so that we prevent any recurrence and outcomes are going to be better and the need for future surgery is elevated. And we know, especially with type 2, it's going to come back most of the times. Yeah. So are you guys thinking about it at Cleveland? Like I already started at majority of the medical clinic with the ENT surgeons where post-surgically, if it's type 2, we are having a discussion with the surgeon and the patient and starting the dupilumab. Yeah.
Well, we haven't actually.
Yeah, please think about it.
We haven't. We'll think about it.
Yeah.
But
we need to have a comparative study, 2 arms,
Absolutely.
one after surgery and one without surgery. That would
yeah,
be-
I mean, I think at the end of the day, it comes to the cost of the, dupi versus surgery. So I think.
No, obviously the cost is more with biologics, definitely in all parts of the world. So when we compare surgery to biologics, usually biologics much more expensive.
Of course.
Yeah, I think there is a study, I don't remember which group, that compared like the approach of surgery versus biologic, and yeah, from a cost-effective perspective, there is no comparison.
Yes, no comparison.
Till the price will be this one. And Ravi, yeah, I agree with you. And many times we had this discussion with Dr. Hamad. So if you think it from the other side, you will be given a highly cost medication to 50% of patients who will not relapse after surgery. So, I mean, yes, I totally agree. And we always do that when, for example, they are doing the second surgery. They say like, okay, I want to do surgery, but they say, okay, you do surgery, it's the second time, you're most likely gonna relapse. I start you straight away on the biologic and you do the surgery.
That's why maybe the EPOS guidelines stresses on having previous surgery in history.
What about, I mean, this is I'm going to throw this and you can tell me what you think. What about using Dupi once patients is in remission and the polyps are gone, use it as needed?
As needed?
As needed, yeah, maybe sporadically, yeah. So patients, whenever they have symptoms, you just give it to the patient rather than them being, and this is the way forward. I think this is what's going to happen. Space it out, and that's what we're doing actually. We're trying to space it out.
Yes, but we don't have a solid evidence that it will work. So
no solid evidence.
Yes.
In fact, I've created a problem for one of our patients. So this patient is, instead of taking it every 2 weeks, I've extended the
once a month.
Once a month. So she ended up with lots of stuff, with lots of Dupi at home. And so the pharmacy said, look, if you talk to the man, they will stop it because she's well. So we just kept it going like this.
Going back to your question, but I think the studies that for which it was approved for a chronic rhinosinusitis showed that after stopping it with 2 weeks, the sense of smell starts going away from the patient. So I think not every patient, I would say, is suitable for spacing.
Absolutely.
Especially with those with loss of smell sensation, especially for a long time. And I have patients with such a success stories when they used it and for like 15 years they didn't smell and now smelling again. But the only take back on that one is that the higher, what is my the personal observation, the higher number of surgeries they had in the nose, the less chance they will ever regain their
definitely because of the scarring of the nose. Yes,
That-
and the first thing to be regained after biologic is the smell also, before even nasal patency. So the smell, yes, depends on the number of surgeries. The more number of surgeries you have, the less, chance to have smell back. Yes.
One of the major things in the quality of life in the patients that was measured after treatment with dupilumab is that they regain their smell sensation.
Yes, and the first thing,
Absolutely,
yes.
absolutely, yeah.